Hi again. Now, let me welcome a Brazilian friend and outstanding clinician, Dr. Victor Clavijo. Victor graduated in dentistry at the Paulista University, UNIP, and then got his specialization in restorative dentistry at Araraquara Dental School, São Paulo State University, UNESP. Dr. Clavijo wanted to pursue his studies in different fields and got another specialization in implant dentistry from the Senac University in São Paulo, also in Brazil. Victor added to his curriculum a master and a PhD in restorative dentistry at Araraquara Dental School in São Paulo University, as well UNESP. Nowadays, he runs a private practice emphasizing restorative aesthetic dentistry and has more than 50 articles and book chapters published in Portuguese, English, and Spanish. Victor will present ceramic restorations, teeth, and implants, details that make a difference. Don't miss every detail of his presentation. See you soon.
Hello, my name is Victor Clavijo. I'm from Brazil and it is a huge pleasure to be in the International Aesthetic Masters 2017. Thanks for that kind invitation and this huge opportunity to share a little bit my work that we have been doing since 2002 when I got my DDS in Brazil, in São Paulo. This kind of online congress, I think that it's very nice because you will meet a lot of people from different countries, from different realities of patients, of clinics, of instruments or resource. Brazil, it's so big, you know, so you can see that this is São Paulo state and I live in a small city that called Indaiatuba. I know that's a funny name, but it's called Indaiatuba. This city was a city that I born in, so I live in this city since the 80s. And when I got my DDS in 2002, I started to work with my father that also is a dentist. The interesting is that I can see some patients that I did some treatments in the past. And I think that is the best way to learn because you can see a lot of mistakes that you made. And I think that experience is the way that you can avoid next mistakes. So I would like to share a little bit experience, a little bit ideas that can help you in your protocols day by day. My topic today will be how to take control of challenge aesthetic cases using the Power Trio Pink ceramics, implants and veneers. Let's summarize a little bit my presentation. We will focus in teeth abutment color, implant abutment color, implant abutment shape, and also the final crown. How is important when you prep subgingival, how is important that the dental technician can understand the importance of the emergence profile. We will start with simple cases that we can perform veneers and the substrate is favorable. And then we will start with a small challenge and then a big challenge, and in the end we will try to apply all concepts that we haven't seen in one case. But my focus in the end is that you can train your eyes, because if you train your eyes, you start to see details that can make the difference, mainly in the interface between gingiva and restoration. So let's see the first case. The first case is a typical case for make veneers, composite, contact lens, partial veneers. But before you start a case like that, we know that we have to do the static analysis, and then we go to functional analysis, and then we start to see if it's favorable to make composite or veneers or contact lens, or also ortho, depend of the Balto discrepancy. But let's try to get focused in these little details. In this case, I decide for some reasons to perform some veneers. So before to perform some veneers, I always like to ask for myself, what is the challenge in this case? So in this case, we can see that we have to think first about the path of insertion. Because when we work with veneers, we can have different path of insertions. We can have horizontal, we can have vertical, we can have 45 degrees. And each path of insertion can provide some advantage or disadvantage. And also we have to think in the type of restoration and preparation, because if we think that we will use some monolithic restorations, we have to have a kind of preparations for press or for CAD. If we decide to use feldspathics, we can think a little bit different. If we think in use some press restorations but not monolithics, we decide to use layer, then we have to prep maybe a little bit more than for monolithics, because we need more space to press and also to layer. This is the same idea for CAD. So when you start one case about veneers, start to see the variety of techniques that you can apply. You have to think in the color that the patient has, the color that you want. You have to think about the path of insertion. You have to think how you can add before make your preparation. Maybe you can add more wax and be minimally invasive. And also you have to correlate this with the kind of ceramic selection, about the ceramic material that you use, and also the technique that the dental technician will prefer to use in your case. So in this case, if we start to think in the details, what color I have? I have around A1, B2, and the patient doesn't want to change the color. He wants as natural restorations. If he wants to change the color, we can perform some bleaching before. But in this case, we will work between K9 to K9, and the patient wants more natural restorations. So we have to see that we can add on top. So we have to evaluate the emergence profile, if we have a convex buccal contour or if we have flat buccal contour. So we also know about some articles that for each color that we want to change, the dental technician needs at least 0.3 millimeters. But in this case, we don't need to change the color. So maybe we can work with 0.3 millimeters preparations. And then for diastemas, we have to decide if we will apply the horizontal path of insertion or if we will apply the vertical path of insertion, or also the 45 degrees. In this case, my option was the vertical insertion path, and later we'll talk why. And I also decided to use feldspathic porcelain, handmade, because if we prep just a little bit, 0.3 millimeters, and if we try to use some analytic material, maybe we can have some problems in the diastemas area because we have a so thin space on top of the teeth, and we have a monolithic material covering or closing the diastemas. So we have different thickness with the same material. And if this material is just monolithic, maybe we can have different colors. And we'll try to explain later more about that. So in this case, we think in these three little details. Which color I have, which color the patient wants. I will decide how much I need to prep. We have to decide about the path of insertion, and also which kind of material I will use, and this will build my final protocol. So we start taking some impression. As you know, the protocol that we like always to take the first impression. We prefer to use putty material we use in this case Ivoclar, the virtual, and we like to take this impression in 2 steps. First with the putty, so we wait 5 minutes, and then we create some space to apply the light material, so we can have this kind of impression, and then we will have this kind of model. So it's very important before you start to work with your dental technician, start to see how about the occlusal plane. We can apply different techniques. As you know, we can use the digital smile design, we can superpose the stone model, we can work with intraoral pictures, but in this case, take a look in this little detail. We have the teeth in different positions. So if you want to place the new smile in the correct midline, correlate with the face midline, you can see that the green line is the face midline. So if I want to have some balance between both central incisors, we have to talk with our dental technician to work more the mesial of the number 21 or the left central incisor, and also to work more here in the mesial of the right central incisor. So we will have different volumes in the mesial area. If you go straight without this kind of reference, probably you will divide here the space, but you can see that we have to add just a little bit here, and we have to add more in the right central incisors. So these are little details. So we start to wax. The wax were performed by Leonardo Bocabella from Brazil. He's a dental technician from Brazil. So he started to wax following his midline that he created, correlating with the facial midline, and then with some caliper he started to measure the space and divide the restorations. We like to always wax with different color from the model, so we can see the exact part that he add, and we also can decide different kind of treatments. If we just apply composite, if we go to veneer treatment. If you go to veneer treatment, we know that we have to prep a little bit. If we go to composite, we just can add. So to talk with the patient, we perform our mock-up, and you can see that the most important picture for the mock-up is to take the facial picture, because if you just work with intraoral, we cannot see the harmony with the lips, with the face of the patient. And also it's very important when you work with minimally invasive preparations to have a perfect mock-up. I mean a perfect mock-up for the chief complaint of the patient. So the dental technician can follow this new design, because when you work with minimally invasive treatment, your provisionals always doesn't look well, because it's difficult to perform this kind of provisional. So sometimes you have to rely on the provisional, you have to add more composite, and you have different issues. So the mock-up will guide the dental technician, not your provisional. It's different when you do a oral or a full mouth rehabilitation, that you can have provisionals for a long term or for a long period. In minimally invasive treatment, you have to be fast in the provisionals phase. So try to make more time, or to have more time with the mock-up step, to decide if the midline is correct, if the occlusal plan is correct, if we have proportions, if the function is correct. So you can see in our facial picture that all it's acceptable, so we can go to our preparation. In this case, before preparation, we know that it's very important to take the color match before you start. Why it's very important? Because if you start to work in the patients and after you try to take color, you can have some problems with dehydration. So to start, we took some color selection. We like to use the normal Vita shade. So you can see that we always try to position the colors in the same position of the teeth. So we try to place incisal edge with incisal edge like this, you know, cannot be in the front, cannot be to the back, have to be in the same position, incisal edge with incisal edge. Otherwise, someone will get more light and we have different colors. We like to use different tones, so the dental technician can choose which one is better. He can remove the color, he can increase the chroma, the contrast, so he can play and decide what will be his type of layer or his type of ingots or blocks. And then we will start our minimal preparation. This slide, it's I want to show very basic article, but you know, you have to learn with the basics, with the roots articles. So you can see that in this article they try to have how is the average of enamel in central incisors. So you can see that usually in the gingival third we have a thin enamel layer around 0.3. These are natural ones. Imagine if your patient has somewhere in the middle third we have a little bit more, around 0.6 to 1, and in incisal third we have 1 to 2.1. So why I want to show this? Because if you want to perform a thin veneer, you have to have enamel under your restorations. Otherwise, the teeth can flex a lot and you can provide some cracks on top of your restoration. And if you have enamel, if you have the enamel dentin interface junction, we can have more strength after bone in our future veneer. So try always to be conservative, but sometimes you have to prep. So this will be correlated with the color that you have, the ceramic material that you want, but try to always think, should I prep more or not? Depends of your box, depends the color that you have, depends of the ceramic material that you want. So also we have to decide the kind of finish line that we will perform. You can see in the left teeth that we can do our veneers without preparations. And you can see in the right situation that we can do a minimal chamfer. This is a huge challenge to decide which one is better. We know as in life we have advantages and disadvantages. The only thing that I can tell you that if you do without preparations, you can see in this SAM that we have enamel, we have porcelain here, and we will have a 45 degrees interface, okay? And if you do a small chamfer, a minimal chamfer, you will have enamel, ceramics, and this kind of interface. The difference will be that one will be a vertical interface and the other one will be a horizontal interface. And this, after some long-term, after some maintenance, we will have some external factors on top of that interface. Maybe we can have some wear with toothbrushing, with some meals, or with some habits. And maybe in the future we can have some wear in this area and you can get some concavities, you can have some staining. But also, if you're not prepped, maybe the dental technician can have some issues to find your finish line. So it's very difficult to know which one is the best option. You have to talk first with your dental technician that if he's able to work without preparation. You have to see the habits of the patient. And I will tell in my clinical experience that we can perform no prep, we can perform no prep interfaces, but it's a challenge for the dentist and the dental technician, because sometimes we don't know if the ceramics are in place, you don't know how to polish these in the correct protocol, and if you do some chamfer, could be more predictable because you can see if the veneers is in place before you bone. The dental technician can finish better the interface, but maybe you can have some different kind of concavities in the future. So it's advantage, disadvantage, but nowadays after a long period trying to get the acceptable protocol for my experience, I always prefer to do a minimal chamfer. Okay, so in this case we perform the mock-up, okay, and we decide not prep on top the mock-up because we just want to prep 0.3 millimeters, and with the mock-up, if we prep 0.3 millimeters, probably we will not touch the teeth. So in this case also we decide to perform the vertical path of insertion. So sometimes when you have to perform the vertical path of insertions, you have to remove a lot of areas that could interfere when you want to sit the veneer. And probably you will remove a little bit more than 0.3 millimeters. If I decide to prep for horizontal path of insertion, probably we will use the mock-up. But in this case, for vertical one, we will remove a little bit more from 0.3 millimeters. So you have to decide if you use or not the preparation on top the mock-up. If you have to prep 0.3 and you can see that your dental technician works more than 0.3, probably you don't need to prep on top the mock-up. Then you will decide that you will do no prep, or if you will do a lines or a finish lines to help your dental technician, and also to remove some sharp angles, some things that can interfere in the path of insertions. Okay, so we start to mark where we have our retentions, where we have our sharp angles. You can do this with some pencil or also you can perform this with some software, with some CAD/CAM. And after we visualize our retentions, we get one burr that is a finishing burr. Always to perform the minimally invasive preparations, we like to use finishing diamond burr, and we use with electric handpiece, and we use around 80,000 rotations per minute. So with this kind of tapered burr, we start to remove the retentions, and also we have to pay attention with the line angles and the middle third in the buccal surface. And when you want to close diastemas, don't forget to go subgingival in the area that you want to close the diastemas. Otherwise, the dental technician not be able to pressure a little bit the papilla and close the space. So in this case, we go subgingival, okay, to remove the convexity that sometimes you can have inside the papilla. We always like to start our preparations without cords, to follow the zenith position, to follow the tissue, and after that we will start to finish our preparations with cords. If we want to go subgingival, we will finish with cords. If we don't want to go subgingival, we'll place cords, but we'll just polish with the cords, trying not to move our finishing line. So also with diamond discs, we start to remove the sharp angles, and now you can see before and after our minimally invasive preparations. You can see that we didn't touch too much the teeth. Why? Because this kind of teeth was a little bit rectangular or maybe square, and you can see that the mesial and distal are not with a lot of retentions. So we could perform these minimally invasive preparations. If you want to close diastemas and you have a triangular shape, you can have some problems. You will probably expose some denting. So before we want to do minimally invasive preparations, try to take a look which kind of teeth I have: square, triangular, oval, and you will see that will be better go to some composite or make some preparations. And also you can see in this occlusal view that we went subgingival in the papillas areas. We create a little chamfer that you can appreciate in these pictures. And I want that you pay attention in this drawing. So if we want to close diastemas and you won't go palatal, if you do this kind of preparations, probably the dental technician will create some step in this area, will create some step. And this could be an area to have plaque retention, to have some secondary caries, will be difficult to polish. So if you want to have acceptable contour, you have to go more palatal to create a uniform contour in this area. Okay? So when you have to close the diastemas, try to have this kind of situation instead of having these kind of situations, because if you want to provide the horizontal, probably you have these kind of gaps that you can appreciate in these kind of pictures. Okay, so usually we can work like this situation. Okay, we can work like this situation. We will remove the sharp angles, we will remove the retentions. We can work also, if it's just a little bit, without water, with air, for not warm up the teeth. And also you can polish with this kind of burrs. So in this case, we also try to remove a little bit the texture. Pay attention to this image. Sometimes you have a teeth or a tooth with a lot of texture, but you add volume, so you think, I don't need to remove anything on top of the teeth. I will leave that texture. But the dental technician probably will place some wax to remove this kind of retention or the concavity. And in the end, when you start to bond your restoration, you have a thick resin cement or a thick composite area. And after you light cure this area, you can have some shrinkage of the composite of the resin cement, that in the future or also in the same moment you can have some cracks. I hope that you never had this experience, but you can have a thick area here between enamel and ceramics, and this can shrink after light curing, and you can have this crack like I had in some cases. So just to summarize, when you have diastemas, try to go subgingival. Okay, try to go subgingival to have this kind of contour instead of having this kind of contour. And also to take the impression, we like to use 2 retraction cords, okay, but we prep just a little bit in the buccal surface. So we will use just 1 cord to not push too much the tissue, so the dental technician can work better in the emerged profile. But for the interproximal areas, we place 2 cords. And then, if you do this, you will avoid this kind of mistake. Look, in this case, we haven't go subgingival, so you can see that step that we have here, okay? And so if we were subgingival, the dental technician could start here and close the space, and you will avoid this kind of situation, okay? So always the diastemas go a little bit subgingival. For this case, we took the impression, okay? 2 cords, 2 steps, putty and light, and the dental technician, my huge friend Leonardo Boccabella, provide the Geller model, and he liked to use this kind of technique that he fixed with pins, and after he will hold with wax, and he will provide the alveolar model. And this alveolar model, he will use a guide provide from the wax. So it's very important to have models with precision, because he will start to layer with the same guide that he performed in the first mock-up. If you don't take care about your first impression, probably this kind of guide will not adapt well on top of this kind of model. So he performed dies, and he duplicated the dies for a refractory die. So now he decided to use the feldspathics because he has a thin space. And if you work with feldspathics, he can close the diastemas with opaque ceramic, and then on top he will place some layered. If you apply some monolithic restorations here, probably you will have here one color and here other color. So the dental technician Boccabella, he start to layer. You can see, you can appreciate how precise he is, how talent he has, and he start to work with the first bake, then the second bake with some enamels, and then to close the diastemas he will use some line angles to verify the size and the transition area. So he start to work in the visual area and try to hide a little bit the natural area, and then he start to finish, polish, apply the glaze, and you can appreciate in a thin space how much he can be precise and how much he can work with opacity and translucency. So Lau take a lot of nice pictures that you can appreciate opalescence, you can see transillumination, and also you can see the opacity in these veneers. And also there's a lot of characteristics with around 0.4, 0.5 millimeters. And now it's time to try in our restorations. We like to use two protocols. First, we work with the dry trying that we will see fit and contact points, and then we will work with wet trying that we will verify the color. Okay, this I will not take too much time because this is just the way that we work, and then we start to create our protocol to bonding our restorations, and then we bonded our restorations in that time just with retractor cards, and we place all in the same time, and we use the light cure cement in this time that was around 5 years ago. We used the Virulink Veneer Plus One. So we finish, we light cure. After light cure, we start our protocol to finish our interface, to polish our interface, and then you can appreciate that using the kind of vertical path of insertion to use the feldspathic veneers with a thin space, you can enhance the tissue architecture in the diastemas area. You can have a health tissue here and also a very interesting color with these kind of restorations. If we increase the contrast, you can see how artistic Lau made these kind of restorations. We can see in a close-up view that we change the diastemas area, and now we have a very interesting papilla, and also we have a health in the gingival third. With the face picture, we can see that we have a huge change. The patient is very happy, but for me this is the most important picture in the end, that we have the 5 years follow-up. We can see a little bit inflammation in the patient for day by day, but the veneer is still acceptable. We have acceptable interface using some ideas that I shared with you. Okay, so try to take home in the first case path of insertion, ceramic material, okay, and how much you need to prep and how could be your preparations for diastemas with minimally invasive preparations. The second case now will be a little bit different, okay? The second case, we have a situation that now we will use some crowns, okay, because we have to replace this crown, and also we have to work in this provisional implant crown that doesn't have a acceptable zenith position. Now we have to think which kind of ceramic material you use, how can I improve the zenith, and also how we can balance the substrates. Because always when you work with metal field restorations, we have to think how we can balance the substrates. So you can appreciate that after removing the crowns, we have different color of abutment teeth. you can see in these kind of pictures that our target will be the lateral. So if we see the lateral is low value with a translucent enamel. So what kind of ceramic material you use? Lithium disilicate, zirconia, feldspathics. I start to see advantage, it's advantage. For our protocol, for our experience, we prefer to use lithium disilicate. But I can have some problems with lithium disilicate. Why? Because we have different teeth abutment. So the question is, how can I change the unfavorable situation to a favorable situation? So we took some x-rays and we decided to retreat the endodontic treatment, and then when we start to perform our anatomic posts, we will customize our fiber post in a customized fiber post with composite, so we reduce the resin cement area and we will have maybe mechanical retention, and this will not interfere in our bond, and also will increase our maintenance of this case. So we perform our anatomic posts, and also after perform our anatomic posts, we opacify, we try to mask the discoloration with some opaque composite. And now you can appreciate that we changed the teeth abutment. You can see that here was dark and now we have some opaque preparations. Now I can help the dental technician to use the lithium disilicate and also give to us acceptable restorations. And in this moment, after I took the impression, Leonardo Boccabella, now we start to work with the tissue. We can manage on top or with the patient, or also we can manage on the top of the model. We have an interesting article in Quintessence Dental Technology this year, 2017. It was an article that I made with Alvaro Blasi. So we try to create some decision-making process, how to customize the tissue, when we have to customize, how will be the protocol. If you have time, try to take a look. So in this case, Leonardo Boccabella made a model with artificial tissue gingiva that was from Zermatt, is the Gingifast, the hygiene. So after he performed the model, he walks on top of the tissue, and you can see that he create a new zenith position, and then he start to be if it's okay with some digital smile design, and he start to create some reference on top of the tissue, and now he will start to cut the tissue, and he will work in the critical area, as the article from Oscar Gonzalez 2012, and it's a very interesting article trying to say where you have to manage the tissue, to work with the zenith, to work with the papilla. So following the concepts from Sue and Oscar Gonzalez and the Pennsylvania Teen University, we customize our tissue, the zenith position, and then we got in that time a prefabricated zirconia abutment, okay, and then to enhance the fluorescence and also to customize, Leonardo actually, he walks up on top of the abutment and he defined the new emergence profile. After this, he checked, and you can see that it's 1 millimeter subgingival. He create the emergence profile of the abutment and take a look that the crown will be very important to hold the tissue and work in the zenith. So after this, he pressed IMAX Zirpress, and you can see in this kind of picture that our friend Cristiano Soares, also a dental technician from Brazil, he showed that IMAX Zirpress MO-A1 has a very high fluorescence. For this was our option, and after this he pressed and we have our final abutment contour, and you can see that we have a translucence, acceptable one. You can see the zenith that will change the tissue, and after this we place the abutment and we have some pressure. That ischemia, that blanching, we know from the article from Wittenben that this blanching, this ischemia cannot be more than half of the adjacent teeth, and also have to disappear in 15 minutes. So we work with our crown, and after 1 week we have this kind of changing in the zenith position. So now we have acceptable abutment teeth, we have acceptable zenith position, and we can take our final impression to perform the lithium disilicate restorations. And also you can see in this picture that if we work with abutments without fluorescence, like just raw zirconia, we can see that the tissue around the implant also will be a little bit dark, and this can sometimes show like a grayish view, a grayish tissue for the patient. So if we enhance the fluorescence with some materials, we can also increase the lightness of the tissue surround the implant. So now Leonardo Boccabella worked with the IMAX lithium disilicate. He made some cuppings and he start to layer on top the cuppings, also using his kind of guides, and he's also performed an amazing layer on top the restoration. This is our first trying, so we can see that we are in the correct path. And then Leonardo applied the second layer. He tried to mimic the cracks that he can see in the other lateral, and he applied the enamel, and in the end he tried to move. He can work with some naturality on top of the teeth. And after his beautiful pictures, we did the try-in, we start our bonding protocol, and you can also see that we got acceptable outcome. Okay, and the most important thing that I want that you take home in this case, try to summarize. Okay, we have this kind of lateral that was our target, so we have to think which kinds of ceramic material can give to me this kind of naturality. So we have to see if we will use zirconia, feldspathics, or lithium disilicate, press, CAD, but also we have to see which kind of abutment teeth we have, if this is acceptable to use this kind of ceramic material. If it's not, we can try to improve, we can opacify, we can help our dental technician. And also when we have different zenith positions, we have to work with tissue management. You have to create a strategy to manage your tissue. Okay, so this will start. This is our final result, and we can see that we are in balance. And this the patient move for other city, and the dentist that is doing her maintenance send me this kind of picture, and we can see that we are in the correct path. So the third case that I want to share with you, we start now with different kind of situations. Okay, in this case we have a lot of lack of gingival aesthetics. So you can see that the patient also has some incisor wear, okay, attrition. He has one problem that it's very difficult to solve. Why? Because he has a mirror concern. If the patient has a huge problem here between two central incisors, okay, he will not compare the central incisors with other central incisors. But if he has a problem just in one side, he has the other side to complain, to see, to compare. So remember, when you have a mirror aesthetic concerns, be careful. Try to create a acceptable strategy, otherwise you can have problems. And also the patient's high hip line. So we can see in the smile that he's high hip line, and after that let's see intraoral. So we have this kind of problem. We can think to how we can improve the unfavorable situation to a favorable. Maybe we can start the case again. Let's remove the implants, let's do a new bone graft, let's try to mend the tissue, but probably in this kind of defect we will still having some pink restorations in that. So we talked with the patient told us that he preferred to go for the quickest option because he's a little bit tired after a lot of surgeries to get this situation. So we start to use our DSD protocol, okay, and with the DSD it's very nice that we can explain to the patient how big is his problem. We can show some ideas about our new treatment plan, that for us our option in that moment was to create a new provisional with a concave profile in order trying to push the tissue coronally, and then we will do some crown lengthening following the CEJ, trying to reduce the problem. Our final restorations probably will be lithium disilicate monolithic because the patient has some wear problem. And also the pink ceramic restorations, we have to think, because we need pink but the implant is too buccally, how we can change the path of insertion of these restorations. So it took one impression. You can see how bad, how poor is the implant position. And we made one provisional screw retaining. You can see where is the access for this. We submerged the other implant. Also, the surgeon Paulo Fernando from Implante Pério Brazil, he performed some soft tissue graft in order to increase the volume and avoid some step in the future pink restorations. So we prepped the center and the left incisor, okay, with minimal preparations. We create a finish line. We try to work with the horizontal path of insertion. We took our impression. We got our model as a Leonardo Boccabella protocol, okay, stone and artificial tissue from Zermatt, Genfast Rigid. And this was the tip or the idea that I want to share. So Leonardo Boccabella decides to use cylinder, a plastic cylinder with a metal support, and then he customized one abutment. He placed some prefabricated thread in the palatal, and this will provide a second screw that will hold our future bridge. So the abutment has two threads, one to screw on top of the implant and the second one for the palatal to hold the bridge. So this is our metal bridge, and this is the way that we will screw in the mouth. And also we know that now we have a big challenge because we have a minimal preparation one side and we have a metal situation the other part. If we try to layer and if we try to balance lithium disilicate with metal ceramics, will be difficult. And if we place feldspathics in the other side, to balance the color will be difficult. We have some problem with the incisal wear. So with Boccabella we decide first try to balance the substrates. So he layered the pink restorations. You can appreciate here how we will screw in the mouth, and you can see also after the soft tissue graft that Paulo Fernando from Implant Perio performed, we don't have a huge step. And then we go for our patient, we place our abutment. You can see the way that we screw. This is the second screw to hold our bridge, and after this we have this situation, and we can see that now we have acceptable abutments. I know that it's not perfect, but it's the reality, and we can see that on top this we can do whatever you want. We can do feldspathic lithium disilicate, we can do CAD. It's your option. For us, our option was duplicate now the pink ceramics, okay, and now we have the stone that Boccabella duplicate his pink ceramics, and now he will wax on top this, and he will perform some IMAX restorations, okay, and these IMAX restorations he made a micro layer on top to get more characteristics, and he works with the line angles, everything that it's so artistic that I would love to have more time to show you. So we tried the restorations. We can see that the restorations are in balance. Try to see the central, the right central incisor and the left central incisor. They are in balance because we balanced before, and then we bond ceramics to ceramics, okay, following the protocol. And we bond in the mouth. This is our final outcome, and you can appreciate that we have acceptable outcome. In the smile it's acceptable, and also in the face it's acceptable. So this is other idea that I wanted to share with you. This is idea when we have a huge defect, when we have a poor implant position, so we can work with a different type of abutment. You can balance the substrates, and you can work with veneers on top of your restorations. This paper we published in Quintessence Dental Technology in 2015, and try to take home, when you have incisor wear attrition, try to think which kind of ceramic material you use. Aesthetic mirror concerns problem, try to balance the soft tissue and the implant teeth abutment. Implant with wrong position, try to customize abutment with palatal access. A huge lack of gingival aesthetics, sometimes you have to work with pink ceramics, and maybe Botox can help this, but was not option in this kind of moment. And to finish our presentation, I would like to show quickly one case that now we have a huge defect, but we have the tooth in position. So now I need a multidisciplinary approach. So we have a huge gingival discrepancy, and the teeth also is not acceptable. So we start to see what is our challenges. We know we have to work in tissue and teeth. The question is how we can start. We know the chief complaint of the patient. She has several ones, and we have to classify the smile. We have to think how we will enhance the tissue, so we will provide our treatment plan. So take a look in this CBCT. We have this kind of problem. How can I start? How can I turn this unfavorable situation in a favorable one? Should I extract the teeth, or maybe we can do something before extract the teeth that will help our final outcome? We can go for some articles. We can see that we have some ideas from Hatzis. We will try to use the envelope technique. We can use some ideas of Bopt technique, and also the way that we will perform the graft. So before extracted, I went a little bit close. I found some crack, but we don't have a huge or any inflammation. So I decided to submerge the root. And after this, I create some concavity. I try to bond the crack a little bit. I reduce the volume of the root, and you can appreciate that now with root submergence, we enhance the tissue surround the defect. And you can appreciate now the tissue, it's acceptable to perform some graft and sutures. So with Paulo Fernando from Implant Patio, he performed some soft tissue graft. Paulo Fernando enhanced the situation. Now try to think, if I extract before, maybe I can have some more problems. So we decided to submerge a root, perform first the soft tissue, and then we got this kind of outcome. And after 3 months, Paulo placed the implant. We don't have acceptable immediate loading, so we decide to submerge implant also and wait 6 months. After 6 months, we can see that we improved the situation, but we still having some lack of tissue. So we perform some prototype of the final restorations, and I decide to talk with the patient. Should we go for a different central incisors? I know that you are tired and maybe you don't want a new soft tissue management, but we can finish like that. So the patient understood the problem and she accepted a new soft tissue. So with Paulo Fernando from Implant Patio, we start to discuss, and he decided to perform the Vista technique, okay, with some modifications. So he got some soft tissue from the tuberosity. He created this kind of incision, and he performed this beautiful situation that you can see that after the graft now we have acceptable situation. If you want to see more about Paulo Fernando from Implant Patio, go to implantpatio.com.br and you can have some videos, some instructions for these techniques. And after we have the tissue healing, we have to work in the second reaperture. But now we have some challenge. If we perform some incision, we can have some problems. So in this case, we are doing our best. So I decided to go further to the literature, and I find this nice article from Javier Vela that he tried to explain how is a non-invasive alternative to second implant surgery. So I decided to start to customize my Pontec and start to apply some composite on top of this Pontec. In 3 appointments, I start to manage the tissue, and when I touch the healing cup, I start to rely on my provisional. So it was a prosthetic reaperture, was not a surgery to rely to capture our provisional. Okay, so you can see our soft tissue managed. Now we have to decide which kind of impression we will do, just with flow and the cup and tray abutment, or try to customize the cup and tray abutment. Or we have other option. We can duplicate our provisional, and then we have in this image our provisional and the provisional that we duplicate, and I decide to prep on top the provisional. Why I decide to do this? Because the tissue is almost acceptable, almost in the correct position. So maybe if I try to take impression, I can make some mistakes. So I decide to duplicate my provisional, prep in mouth, so the dental technician can understand how should be the final abutment. So I also performed the preparation subgingival here for the teeth, and I took the impression. Leonardo Boccabelli started to work in his kind of models. He started to walk, and this time he visualized that we have some different tissue here. So first he started to see that the tissue is a little bit up in the implant position. Now he has 2 options: push a little bit the tissue here, or create some concavity here, okay? So after the wax, the final wax, he start to see the tissue, he start to see if he need to cut or not, and after he organize and he finish the tissue surround the implant, he just enhance a little bit my abutment, and he perform a final zirconia abutment, a hybrid zirconia abutment. And this is very important. If we want to work with aesthetics, he can get our final zirconia abutment, and we can also customize color. So Leonardo decreased a little bit the volume in the first millimeter, and now he tried to copy the color of the natural abutment, the tooth abutment, and with some ceramics he start to place some color to customize shape and color to not interfere in the final result of our crown. So you can appreciate how Leonardo Boccabella enhanced the color of this abutment. And after this we can go to the mouth and we can try to see if everything okay. And after this he performed 2 crowns on top our abutments, and this is very important, okay? Try to take a look. I know that it's a lot of details, tips made can help you, but this for me is one of the most important tips for this kind of conversation that we had in this 60 minutes. So you can see that he creates some concavity here, okay, in order to push the tissue a little bit coronally, okay? You can appreciate also in this image. So after he managed a little bit the emergence profile of the crown, we can appreciate that now we have almost the same zenith. And let's try in this in the mouth. You can see that when we try in the mouth, you can see this kind of defect. But if you have a lot of volume, a lot of tissue, and you remove pressure, probably this tissue will come down. Probably, no, we can affirm, we can be sure that the tissue will come down. So we torque the abutment, okay, we start to work with some composites, we create our protocol to bond our restorations, okay, we use dual resin cement. We prefer when we have a little bit dark substrates to work with opaque resin cement, and we have to bond zirconia. We like to work when we have zirconia abutments to work with the Professor Marcus Blatt's technique, the APC, okay. We are blasting the zirconia, after we will apply some metal primer, and after some resin cement, okay. And after this we bond. You can see that doesn't look acceptable, but if you follow the ideas, if you have tissue, if you create concavities, you can see that in 2 months the tissue come down. And the most interesting thing in this case, try to see that we have a lot of work, but if you think a little bit outside the box, root submerge, okay, before extract soft tissue, different ways to perform your soft tissue, you can achieve and you can get this kind of acceptable outcome. And I like that the patient's very happy, you can see her smile, but this is a kind of view that you can see that after a lot of surgeries, we achieve this beautiful outcome, this beautiful tissue management, these beautiful surgeries from Paulo Fernando from Implantpédio Brazil, that was a plastic surgery because you cannot see any scar after this. So I also want to share 2 years follow-up of this situation. We can see that the tissue surround the implant is acceptable, the papillas, and maybe now the grayish brood is calling our attention more than the implant tooth. So summarizing our lecture, let's back for our first slides, okay? Try to train your eyes for details that make the difference. Try to check teeth abutment color, implant abutment color, implant abutment shape. So then, always if you have a cement crown with subgingival preparation, try to talk with your dental technician how you perform this concavity, how you hold the zenith, okay? Always trying to achieve a beautiful interface between gingiva and restorations. It's time to finish, so I hope that you could take some ideas of our protocols. I hope that these ideas can help you in your practice. And if you want more information, if you want to share some experience, you can mail me for Clavijo Victor at yahoo.com.br. And also, if you want more information, you can go to my website, that is victorclavijo.com.br. Have a beautiful Congress. Thanks so much for this moment with you. Take care.